I think we're working, which is fantastic. Don't know if anyone's on yet. Okay, so I'm on. Hi, Trish. Okay, so hopefully this time round things work from an internet connection perspective. We had issues the other night where I just kept logging out every 5 minutes. I just finished operating at Brisbane Private. We had a big day. We started at 7:30 in the morning and I finished at 6:27 at night before having to start at 6:30. Got lipectomies, breast lifts, all sorts of stuff, and reached a point where obviously still stuck in the hospital. There were issues with internet connection. Anyway, I'm in the office now, and so things should be good. By way of introduction, I am Matthew Peters. I'm a plastic surgeon based in Brisbane. I co-own a practice in Fortitude Valley called Valley Plastic Surgery with Ray Go. We set this place up in 2014. We found a building. We've been working together for years and thought we'd go in together. It was a pretty big venture. It's a big practice. If you've been here, you would know. It took us over a year to get it up and running by the time we'd done the fit out and everything. And yeah, so anyway, here I am. I'm also the Director of Plastic Surgery at Royal Brisbane Hospital, and I've had that position since 2014. And that's a busy place, and there's a lot of work that happens there. And yeah, and so I am involved with the breast clinic there, and that deals with breast reconstruction, but also breast reductions and complex breast issues after cosmetic disasters. We also see congenital issues and the like that come through there, tuberous breasts and things like that. I also do pelvic surgery and other bits and pieces at Royal Brisbane Hospital as well as being on call. But the majority of my life is at Valley Plastic Surgery with Ray, and we've now also got Theo Birch, Andrew Hadge and Brendan Louis, as well as the dermatologist Kate D'Ambrosis. So it has progressed well. So tonight is all about body contouring, and that can mean anything. Plastic surgery is all about the body, and that basically is from head to toe. Most of the time when I think body contouring, it's in relation to massive weight loss and correcting things after losing lots of weight. But it can also be issues relating to the breast and recontouring those. And that can be something that's a breast reduction type scenario. It can be correcting breasts after some sort of other cosmetic issue, whether they be old implants or implants that are too small, too big, gravity, all these sorts of things. So body contouring can obviously be in relation to that. Don't forget about the face. So if anyone has any questions about facelifting, that's fine. But the big areas, the big ticket areas, obviously looking at belt lipectomies and arms and thighs and all those different areas like that. So if you have questions that are specific to those things, by all means, fire away. But keep in mind, I am a plastic surgeon, and anything that is plastic surgery related, just give me a yell. Some of the questions that that came up the other night that I did sort of try and address, Mandy's printed out for me, and some of them are pretty good. So most common body contour procedures: belt lipectomy, abdominoplasty, dealing with the medial arms, dealing with the medial thighs. They're the common ones, more so than any, and of course breast lift, breast reduction, and a breast augment plus or minus lift. So just rejuvenating the whole chest area, rejuvenating the abdomen, rejuvenating the arms and legs. They're the commonest things that I do. Tuesday, when I was trying to get all of this done, I just finished doing a belt lipectomy with a breast lift in a young lady who lost lots of weight through diet and exercise. You know, these are big operations that take 4.5, 5 hours, quite commonly for that sort of combination of stuff. And yeah, but that combination, doing breasts with the tummy, is super common. I've got a question here from Tracy Lee, which has popped up, so we'll answer that. And that's, what is the normal recovery time for a tummy tuck? All of my body contouring procedures, breast, everything, I give people a guidance of 6 weeks. And I like to sort of counsel people that you've got to wear a compression garment of some sort and consider it like a plaster. You break your arm and you have a plaster on. Well, you go and do all this work to your abdomen, wherever it be, and there's some sort of splint. There's a garment on which is to keep everything just nice and well supported. And I find that I've got to have that on for 6 weeks to keep everything just well supported from an edema perspective, but also a comfort perspective. Does it take 6 weeks to completely recover from a tummy tuck? No, it does not. Okay. The first few days, obviously, you're in hospital. We've got to get your pain under control, and it's not that bad a procedure for most patients from a discomfort perspective. But I've also got to get you mobilised. I've got to get your bowels working. I've got to get your bladder functioning well, and then it's home. And usually with no drains in, but getting you moving, getting you up every hour, walking, getting to a point where after a couple of weeks you can entertain getting back to work. Certainly thinking about getting in the car, trying to drive, being able to do an emergency stop is like your legal requirement. Getting up and mobilising well and getting back to normal employment, especially if it's office-based, after 2 weeks is fine. I do lots of tummy tucks on nurses, and nurses are a good gauge. It's a very physical job. They're very active in their employment, and they're running around having to look after patients one-on-one, two-on-one sort of thing, and so they have to be super physical. And most nurses find that they need 3 to 4 weeks off from an abdominoplasty or a tummy tuck in order to return to their gainful employment and be fully functional. So I use that as a gauge for individuals who have a job that's a little bit more physical, and that also includes people who travel a lot, are at Air Force all the time, or are having to get out and about on job sites and things like that, where they might have to do some lifting. So yeah, tummy tuck, to answer your question, office-based, really physical, 6 weeks with a garment, and then progressively going from activities of daily living, first 2 weeks, and then getting to the shops, pushing trolleys, carrying milk bottles, all of that back in the house for 2 weeks, and then getting a bit more active in terms of reaching down to pick up heavy things, reaching up to stretch and hang out washing and things like that in the final 2 weeks of that 6 weeks. And then by 6 weeks, usually pretty good, unless you're someone who is super physical and really active and looking to do crunches and all sorts of abdominal exercise. I say, hey, slow down on that for 12 weeks. But certainly after 6 weeks, returning to gym and classes and Pilates and yoga, usually safe. There's a question here. I've had lots of weight loss. I'm looking at breast augmentation, thigh, and maybe tummy work. Can you do it all in one procedure? And is it recommended to do this much work at once? It comes down to how big you are as a person and how big the job is. So if you are a small person and we're looking at tummy and breast, that's fine. I've got to think about how safe it is to do this sort of surgery, how long it's going to take, and that transpires into what your potential risk is from a DVT perspective, so blood clot in the leg, how long you're on a respirator for, and what potential risk that might be to your chest when it comes to potentially developing pneumonia. It's things like that I've got to factor in as to how safe it is and how long you're on the operating table for. I find that for most patients, doing thighs and tummy in one operation is not clever. It's just too much discomfort down around the pelvic area, and that's based on feedback from patients. So to answer your question, can we do a breast augmentation and a tummy tuck in one operation? The answer is yes. To do thighs, breast, and tummy is a big deal. So I really have to assess the patient in front of me and see how feasible it is. I have done it. I have done breasts, arms, and tummy. I've done belt lipectomies and breasts. I've done belt lipectomies and arms. But doing the thighs and the tummy, I sort of draw the line out because it's a bit uncomfortable. But I'd have to assess whether breast and tummy can be done in one hit. And usually the answer is yes. There's a question here. I'm worried that I may have a lot of adhesions from multiple previous abdominal surgery. Will this affect my tummy tuck? The answer is usually no. I did general surgery first. I did it for 3 years, and everything that we pretty much do in abdominal surgery is intra-abdominal. So the adhesions that you might have been told you have are all around the bowel. They're all in a cavity where we go nowhere near when we do when we do abdominal surgery. That's a tummy tuck. So, of course, the caveat to that is making sure that you don't have any herniation of any thing through your anterior abdominal wall, looking at positioning of scars and making sure that whatever I'm doing from a tummy tuck perspective is going to be safe and feasible, making sure that I'm not going to put you at risk. So adhesions from multiple previous abdominal surgery, will this affect my tummy tuck? The general answer is no. I'm going nowhere near abdominal contents, which is where adhesions fall. Right, so other questions from the other night. Can you have more than one procedure at a time? I sort of was mentioning that in relation to can we do the breast augment and a tummy tuck and thighs, and it's really common to do multiple procedures in one hit, mainly because it's convenient, and you need to factor in downtime, time to have an operation, general anaesthetic, recover, get back to normal function in terms of activity. Most people don't have oodles of time to take off work, so you've got reasons why you exist, and you need to earn an income, you need to do all those things. So doing more than one operation at a time is super common. So it just comes down to what we're dealing with, how long it might take, how safe it might be to do that. And so, yeah, it's really common for me to do belt lipectomy, lower body lift, in combination with breast reduction or lift. Very common to do abdo alone with breast, very common to do belt lipectomy with arms, very common to do arms with thighs. I've done facelift with breast reduction and lift. So there's things like that that I can put together as a combination to make it more convenient, but it's just got to be safe. I've done 3 areas at a time in smaller people. So where I've got less tissue to mobilise, to lift up, all that sort of stuff, less stitching to do. It's just an issue of time. I'm not the fastest surgeon in the world, but I'm not the slowest. But I do like to give enough time to do the job right, and you've got to think, okay, well, the average times of this and putting it together, how safe is it once we have that one. So yeah, I have done arms, back bra lift, tummy. I've done lower back lift with the breast lift and arms. So sometimes the triple type area is possible, but it just depends on how safe it might be when it comes to time. An anonymous question has come through. Thinking of booking in with a general surgeon that does many tummies in Rocky, but I'm a bit unsure. Can you give me your opinion? I'm never going to comment on the professional standards, qualifications, or otherwise of another surgeon. I just think it's unprofessional to do so. It just depends on spending time with that individual and seeing what they've done, what their techniques are, what sort of credentials they have. Okay, I'm a plastic surgeon. Plastic surgery, I guess you can see all that stuff behind me. That took 17 years to get this qualification. Finished high school, science degree, medicine degree, surgical degree, basic surgical training, advanced training, general surgery, 5 years of plastic surgery training, post-fellowship training. So I didn't qualify until I was 34. So it's quite a bit of effort involved. It's very different, and when you finish your training, you then have further things that you have to do, and you spend time traveling around and seeing how people do things, and it's building on technical things that you've learnt. So there's a lot behind the scenes that has to be achieved to reach that point, and that's what you have to compare against. I'm not saying the person up there is not qualified, but you've just got to consider what they're doing in comparison to the training of others. The training that I went through was really, really intense, and I look back on it, and they were huge hours. There were multiple nights where I would be at work until 2, 3, 4 in the morning. I have 4 children. I actually can't remember much of my two oldest children in terms of them growing up, because I was just working so much in the hospital. So yeah, where we were and what we were expected to do and all of that was really full on. And but it's a good basis for training, and it's been the basis for how I do things now. So yeah, that's sort of what you're comparing against. Plastic surgeons are considered the benchmark for this sort of work, and we're pretty confident saying that because we've got the training to back that up. So you just need to compare that against what you're potentially considering up north. I hope that's answered. And as I said, I don't like to comment on the professional status of someone else. It's just against my nature. Other questions from the other night where we kept getting interrupted by things with my internet. There was a question, is it better to wait till after having babies to have an abdominoplasty with lots of excess skin? This is a really interesting question. You've got to think of the long-term stability of a tummy tuck in terms of, you know, why you're having it done is because there's extra skin, there's an appearance issue, but there's also a functional issue for lots of women when it comes to how much of the muscles have been stretched up. Personal experience with an individual who had 2 children found that their second pregnancy really stretched their rectus abdominis muscles up very significantly to the point of having a hernia centrally. And they went on to have a full abdominoplasty, tummy tuck, hernia repair, and then a number of years later fell pregnant. Commentary from that individual when, this is not a patient of mine, but someone that I know, and the commentary from them was that their third pregnancy, they carried a lot better. They felt that the muscle repair, it was intact. That individual's gone on to have a 4th child, and that pregnancy again was fine, and how their abdomen looks now compared to how it was after 2 babies is still a really stable result. So has that person got loose skin more so than what they had after the tummy tuck? A little bit, but not massively. And certainly from the functional perspective, in terms of, you know, it's part of why you have a tummy tuck is to improve your function. That individual is certainly very happy that they had a tummy tuck, and it was tested out with 2 subsequent pregnancies. There's not a lot of research behind that. There's a few papers that have got anecdotes that are similar. The largest paper that I found at the time was 4 women who'd been through a similar thing. That would be something that you've got to weigh up. That particular individual does have a little bit more excess skin compared to the ideal abdominoplasty scenario, and it's because they've tested it out, stretched it again. So think of the functional concern. If your muscles are significantly separated and you think, hey, I feel like I've got no core strength, I've got none of that, and you just want to have it all brought back in, then certainly if you're accepting the potential to have the need for visionary surgery to tighten the skin up, then considering abdominoplasty might not be such a bad thing if it's a real functional issue. There's lots of questions coming through now. I don't live in a major city, so I would need to travel for surgery. Typically, how long would you like a non-local patient to stay in town, and when would it be safe to fly, say after a breast augmentation? I like to treat patients as if they are basically living in the room next door. And so I like to look after my patients, and I like to make sure that they can get in touch with me. I like to make sure that they're safe. And if there's a problem, I like to make sure that it's me that's able to look after that problem. Problems can arise though, and can occur anywhere out to multiple weeks after breast augmentation, for example. I deal with lots of people from up north, from Darwin, from Townsville, Cairns, all sorts of areas that come down to Brisbane to have that sort of surgery done. My general advice and counsel is that you hang around in Brisbane for a week, because that's the time where I'm more likely to see a hematoma develop than anything else. It's a personal rule that I see before you leave. So, you know, if I operate on Tuesday, I like you to sort of come back following Tuesday, Wednesday. I just check things out, make sure it's safe. There's so many commercially available flights, so they're easy to book at the last minute. And so once we sort of have that sign off, then head home the next day and everything's fine. Having said that, I have been called out by a hematoma. I saw a lady and said, yep, you're great on Thursday. And I got a phone call on Saturday morning saying, hey, I've woken up with a swollen breast. And it was the sort of thing that rapidly I thought, how am I going to manage this? you are 2,000 kilometres away from me. In the ideal scenario, if it was stable, I would have said, great, let's work out if you're medically safe to come down to Brisbane so I can manage it fine. In her particular scenario, her hematoma was increasing, and I had to rely on a local plastic surgeon who was good enough to help me out and my patient where they lived. And that's sort of the network that we as plastic surgeons have. I'm a member of the Australian Society of Plastic Surgeons and the Australian Society of Aesthetic Plastic Surgeons, and we catch up regularly at conferences and meetings, and we've got chapters that are local within Queensland and the like, and we know our colleagues. And so that sort of thing where you are from out of town, I can put a cap on how long I want you to stay so that I can pick up the small things and manage it personally. But for whatever reason, if you need to leave, then I know that I've got a trusted network, and they're a group of individuals that I know have had a certain amount of step training, same to me, and we can rely on them to help out, and that's just good collegiate behaviour. I hope that answers your question. Specifically after a breast augment where you mentioned, as I said, I usually like you to hang around for about a week, but it's a case-by-case basis. So I need to meet and discuss. All of my patients go home with my mobile phone number. I haven't changed my mobile phone number since 1996, which is when I got my first phone. And so all of you have it, and I like to know about small problems and big problems, any problems. So and that's something that an interstater or someone from a distance away, it's a rule that I know the problem and I try and manage it no matter where you are. There's a question here about sole parent considering a tummy tuck. I'm nervous about the downtime without a lot of help. Can you give a general guide to the healing process and downtime? We were talking about this before, and sole parent, you're going to have a bit of time in a hospital. You're going to have to need to have the nurses look after you. You've got to get your bowels going, your bladder. You've got to get up with physios. You've got to get moving. So there is a little bit of downtime that you've got to factor in where you're not in the home environment to look after the child. And so that on average is 3 to 5 days. So with that in mind, that's the first part. The next part, I counsel people, it's 2 weeks of self-care. It's you're pretty much looking after yourself or doing things that other people can't do. So if you're a sole parent, consider the age of the child. I mentioned earlier, I've got 4 kids, 13, 11, almost 5, and a little fella that just turned 1. And those that have had kids will know that a 1-year-old versus a 13-year-old is a massive difference. And so you've got to factor in how old's the child, what commitments, what do you need to do for that person when it comes to school transport, and are they 1 and they need everything done versus someone that you can say, right, today you're in the bus and off you go. Someone who you can give some direction to about help with lunches, help with the housework. Roll my eyes at that regarding children their age, but when it comes to how responsive is that person to your general sort of direction. So you've got to factor that into it. So if you're a sole parent, think of the age. The ideal is that you look after yourself for a couple of weeks, and then you can start to do more around the house. Of course, elective surgery, abdominoplasty, you can plan a bit. So you can think about, okay, the individual involved, what sort of sports you can get, what sort of things you can do to help in the home environment for when you aren't able to do so much. So, trying to think about getting the house as clean as you can, or doing the major things that you normally sort of look to try and do, so that you don't think about trying to do them while you're needing some more help or some more rest. Think about planning meals in advance and sticking them in the freezer, things like that. So a couple of weeks of just downtime just for self-cares, and then starting to get a bit more active. So after a couple of weeks, you should be fine if you put in some simple, safe measures. All right. There's a question here. I hope that answered, Sammy. If it didn't, let me know. I'm scared about starting back with exercise. Hi, Shay. I'm scared about starting back with exercise following MR 8 weeks post-op, as I feel it pulling with general actions. I lifted my granddaughter on the weekend and I may now have a hernia. What's the advice to get back into it safely? Thank you. It's the same sort of stuff. Like I counsel my patients about garments and using garments that act as a splint and remind you that you've had things done. And thinking about slowing yourself down. You've got to, for the first couple of weeks, just do minimal things. I pretty much tell my patients to be a T-Rex. They almost all laugh at that, but it's pretty true. I just sort of say, hey, you're going to be here, you're brushing your teeth and you're eating and you're doing your hair and you're getting dressed, and that's about it. And so if you do that sort of stuff, you set yourself up to get through that first couple of weeks of really intense healing, lots of inflammation, swelling, all that sort of stuff. Beyond that, 8 weeks post-op, feel that it's still pulling, you've got to think about what sort of repair and listen to your body. You've got to actually think, okay, if something's hurting, I'm pushing things a bit hard. To feel that you've got a hernia, that needs to be investigated. You need to see a surgeon and actually get them to assess that. But yeah, getting back into it safely, it's good preoperative counselling to sort of work out, okay, what's an expectation, what should you be doing, thinking about the context of you. And so when I see patients, and it's really common, I'll ask, what sort of hobbies do you do? Like, what sort of things do I need to know about to factor into your recovery so that I can give you directed guidance on what you can and can't do? So thinking about, everyone's got a job. Thinking about how active they are at work versus not active, thinking about how they get to work, thinking about what sort of sports they've got at home, and then thinking about gym memberships and walking a dog, thinking about rural patients that have farms and things where it's really hard to factor things in for recovery. So you've got to think of the person and the context and try and set things up pre-operatively so that we can minimise harm. And so, yeah, getting back to your question, what advice? It's in the pre-operative counselling, it's in thinking about the garments, thinking about a return to activity, thinking about, 2 weeks of this, 2 weeks of office-based, lots of, stretching out at kitchen-based sort of level, and then 2 weeks of bending down and reaching up, thinking about weight restrictions. I counsel my patients nothing heavier than car keys for 2 weeks, and then nothing heavier than a couple of milk bottles for 2 weeks, and then starting to increase progressively to normal sorts of things that you would lift. But beyond that, thinking sensibly about not jumping back into the gym and doing heavy weights and things like that. So they're just general advice points. I hope, Jackie, that's giving you some advice and guidance. But if you're worried about a hernia, please make contact with your surgeon so they can assess. How would we assess clinically and consider an ultrasound scan to see what we're dealing with? You might be surprised. A lot of the repairs that we do, we sort of, one stitch it again. So the repairs usually tend to be pretty robust. Okay. So people saying hello. How much time do you need off work after having tummy, arms, and legs done? Again, it comes down to what sort of work you do. So if you're office-based, my advice is very different to, say, someone who works in a store, and lifting heavy things. Very different to nurses that are working in operating theatres or on the wards with heavy patients and rehab facilities. Very different to people who are physiotherapists and things who are very active in their job with their hands. So the context of who you are and what you do is incredibly important when it comes to any advice. But in general, I recommend tummy, arms, and legs. I don't tend to do legs with a tummy just because I think it's a bit too uncomfortable. But arms and tummy, I tend to find that most of my patients after 2.5 to 3 weeks are getting back to a point where they can lead a pretty normal life. So in my mind, that's someone who I walk out into the waiting room and I see someone who's walking upstairs and they're saying, "Hi, Matt," and they're pretty straight and they look comfortable. They're not needing too much in terms of pain relief. And they're able to sort of mobilise into my room and sit down. They're able to mobilise into areas where they're getting dressings done. They're able to sort of, be a passenger in a car or even consider driving themselves in. And that's someone who, with the right advice and guidance, can be back in an office job, or they can be in a job where they're maybe a little bit more physical. But I always say, hey, have a friend. If you're in a really physical job, have someone who you trust in the workplace. Plastic surgery is usually a really sensitive topic for someone, so you want someone who you can have as a confidant and you can sort of say, hey, I've had this done, you know that I've had it done, and I've still got to do a job. Can you help me with this activity? Or instead of me going to go and do that because it's going to be really heady, you know, are you able to do it instead? So sometimes having those relationships and fostering those as part of that pre-operative planning can be incredibly helpful to get you through. Jay, thanks for your kind words. You've got a lovely outcome. I think your photos and how you look is awesome. So thanks for your kind words. Julie Hogan, do you think I'm best to wait for abdominoplasty until after my wedding? I may only have 2 months healing time. Is this enough? I'm also having breast reduction and lift. I tend to find with tummy tucks that the issue is swelling. Okay, and if a tummy tuck is done well, then you should heal well. You shouldn't have any major issues in terms of complications. The common complications that we see in a conservative abdominoplasty, occasionally get stitches that want to sort of break through a wound, so we may have some subtle wound healing issues to consider. Swelling is the longer term thing. It's rare to have infections. It's rare to have significant ongoing discomfort. It's rare to have wound breakdown. So most of the time, it's a 6-week plan where I see about 90% of swelling having resolved. So keep that in mind for your wedding dress and how it's going to, what sort of planning you've got to do to fit into it. 2 months before surgery, you're probably pretty safe because the overall risk profile to you is pretty low by that stage. I always say to anyone though, and a number of you patients of mine, anyone that is planning on something major or is planning on travel or there's something really big coming up, you've always got a plan for the unknown and unexpected when it comes to potential complications. So if I have patients that are saying, right, I'm traveling in 6 weeks' time and I want to have this procedure done, the number of times I'll actually counsel someone and say, hey, this is elective, or this is a really slow growing, you know, small little skin cancer or something like that. Things can go wrong, can affect your ability to do this particular job, this lifetime, you know, dream holiday. You know, think of that sort of thing, and I often counsel people to sort of come back and have it done when we don't have those stresses involved. This is about as out there as I get when it comes to life, having a tie that's not blue. So the advice that I often give to people is pretty conservative. I'm a worst case scenario sort of guy. So, you know, I always think if it were me, what would I do? And certainly if you have a couple of months to get ready for a wedding, you're probably pretty safe. But anything shorter than that, I'll be thinking, you know, just from a planning perspective, I've been married 15 years in December, and admittedly, my wife organised the whole wedding. I just basically had to get a suit and a tie. You know, there's just so much to do. So you're going to be really busy in the lead up. So factor that in, how that fits in with that 6-week sort of recovery plan. You've got to get to that point where, yeah, you're over the line and you're enjoying the day without harm. The breast reduction and lift, that comes down to the T-junction, okay? And that can be an ongoing concern sometimes if the lift runs into any trouble there. That wound can be a bit of a nightmare for some people. And in my mind, I've had 3 patients that have had wound issues there in that T-junction, and it has just gone on a bit. I personally get a bit stressed when you do get a T-junction issue around an implant because it's not far away from the implant. So if we get an infection there, you can run into troubles that then mean the implant needs to come out. So your dream and your ideas of how you want to be on your wedding day can be significantly altered. But a number of months out, you should be okay to get to that point, but you just have to be reasonable with the expectations and how you're going to manage complications during that stage when you're otherwise super busy. All right. Julie, let me know if that hasn't answered everything for you. Jack is getting an ultrasound on the line tomorrow. Good. Carolyn, hello. How are you? And Julie, woohoo, thank you, doctor. Good. Now, if I go back to some of the other questions from the other day, would I recommend breast lift reduction and augment in one surgery for a patient that has grade 3 ptosis? So This is a great question, and this is one of those ones where I'm involved with surgical training of the next group of plastic surgeons. I was at the Royal Brisbane this morning, and there was a shoot given by one of the other guys, Kieran Rowe, and just listening in and seeing what these guys are learning. This is one of the common breast questions, and it just comes back to safety. Like, you've got to do something right for someone that's going to be safe, or as safe as it can be. The whole risk-benefit seesaw. So when we look at a scenario where we're thinking lift augments, or augment mastopexy is what we call it, then we've got to think, should we be doing this in one stage, or should we be spacing it out? When would I space it out? I would space it out in someone who has really stretched up skin, someone who's a massive weight loss patient, or they had macromet, like really big breasts during breastfeeding, and then we've got the situation with the breast tissue itself is deficient, but the skin envelope is really stretched. And you're looking at a scenario then where, if you think, okay, I'm going to put an implant in and I'm then going to try and tidy all this up, you can have really deficient skin with, stretch marks essentially are stretch marks. Skin might be yay thick, and then you stretch it out and it's super thin. So the ability of that to take a stitch and heal is severely compromised. When it comes to this scenario, I look at the skin, I look at the breast tissue, and I look at, what's the safest thing to do. If I'm going to do it as a two-stage, if the skin is really stretched and just not that healthy, then I would counsel someone to have a lift first, so that I can cut out all that skin and just get back to good, healthy skin that closes, not under too much tension. I have to factor in, though, the distance from the nipple down to the fold, because when I put an implant in, and so I'm thinking of this as a stage procedure, I'm thinking, okay, I'm going to be putting a 400cc implant in here, and there's certain distances that I have to keep, otherwise the scar can lift up a little bit. Sometimes I have to cut everything out and limit the scar length a bit, and so the scar can ride up slightly out of the inframammary fold. So it's a question of, if the skin is really stretched up, then I do a lift first. But sometimes if the skin's okay, but you're thinking, okay, it's better to do this as a staged procedure, then I'll talk to the patient about what their priority is. And, think about how many times someone might see your breasts. And, most of the time it's a partner, it's you, and it's your plastic surgeon and then nursing support staff. So if it's suitable to have an implant put in first and get that whole complex done first, and you're happy to wear that in bra and clothing, and think of the people around you and the support network, and if they're happy to sort of see a bit of loose skin that then needs to be re-draped onto the breast, then that's one way of doing it compared to doing lift first. Okay. Majority of the time, though, I find in my hands that I'm able to do an augment mastopexy in one operation. And that's just, I have a particular technique that I do, and it's, I do it as a stage thing where essentially on the table, I'll do the implant first, and then I modify my measurements based on how everything's looking. It's a really complicated operation, an augment mastopexy, and there's quite a few decisions to make along the way, just based on the thickness of the skin that you find, and how tight things might be around an implant. Worst case scenario is to cut out too much skin, have it too tight, and get T-junction breakdown around the point of the implant, potentially introduce infection, and then have implants being taken out. So that's our biggest fear. But if things are done right, most of the time we can do it as a one stage. Is that the advice that we give to our trainees when they're going through? The straight bat, fast bowler, I'm just going to play this simply, is to say do it in two stages. And there's no harm in doing it in two stages. But I tend to find that once you've done enough of these, that you can do it safely in one. But everyone's different, so you need to get a good opinion from your plastic surgeon as to what's right. I hope that's answered that question. Now, there's a question here about breast implant illness. So much talk of this at the moment. I didn't see the first half of this live. Sorry if I already asked. It hasn't been asked yet. This has come up recently. Now, there was a position statement that was released by Mark Ashton, who's the president of the Australian Society of Plastic Surgeons, on Sunday night in response to the Channel 7 program talking about breast implant illness from Pete Evans' wife, who Pete Evans is the paleo type guy. Now, the position statement from Mark Ashton was that we just don't have any evidence to suggest that it's a definite entity. Certainly, there's lots of people with implants in place. And when you have an implant put inside you, it is a foreign material and your body recognises that it's foreign and it walls it off with a capsule. Now, a capsule is an inflammatory process. It's like anything. I injure my hand, I have a cut, and you have inflammation and the body responds and heals. So same sort of thing happens with an implant. Same thing happens with any implant, hip, knee, finger joints. We put implants as surgeons in lots of different areas to address a functional concern. So many of them are made of silicon. Silicon is a naturally occurring element that is in the soil. So anything that you eat that comes out of the soil has silicon in it. We all have silicon. I have 0 silicon implants in me, but I know that if you tested for my body content of silicon, it would be there. Now, breast implant illness, what Professor Ashton's position statement on, which I support, was that everyone is different and the inflammatory process and how you respond to that is variable. And some people have really strong inflammatory states in response to minor trauma, things like this. So we're not discounting that some people might be experiencing this. We expect that it's a minority thing. There's lots of people with implants who are walking around who are very healthy and fine through all areas of the body, in addition to just the breast cohort. I think that the presence of it in the press at the moment, it's like lots of things. When it comes to plastic surgery, there's a bit of a sensationalism. I'm not wanting to downplay this, but it is one of those things where it gets a lot of attention, and I think for the majority of the people, it's not relevant. I get concerned. Carolyn, you know me, and you know that a lot of my patients are breast reconstruction patients. They're not just straight up cosmetic augmentations. And I get really upset when things like this happen, and I think of the patient who has had breast cancer, or they've got a really strong family history of breast cancer, and they have no choice. As in, you get a 25-year-old, I recently had an 18-year-old who has had a mother, all these people pass away from breast cancer. They need to have their breasts removed. They're 55, 60 kilograms. Their breasts are part of their image as a young woman, and they want to remove that risk and yet still look feminine and be able to have clothes and not be concerned about relationships and all sorts of things that breasts, for whatever reason, have as a personal concern. So for that individual who has no other option except to have an implant-based reconstruction, when they see all this talk about something that's not completely supported by evidence, it's a bit sensational, it might affect their decision to either undergo life-saving surgery because they don't want to live flat-chested, or they might not consider a reconstruction, which then can have significant psychological consequences. So I'm not discounting it, but I do think that it's something that requires a lot more investigation to actually see the relevance of it, the true incidence of it, the basis of it. Is it real? What's the cause? All of those things before it becomes a widespread concern. So, Carolyn, I hope that answers it. But I truly am a surgeon that does lots of breast reconstruction and lots of cosmetic reconstruction in cosmetic cases, and I feel for all of them. I do worry about that cohort of breast recon cases and who can only have an implant. They don't have enough tissue for me to move their tummy up to make a breast out of, for example, and the psychological benefits of having reconstruction are well published, and for them to listen to something that's not true or not supported 100% with evidence and have that influence their decision, I think is really upsetting. Okay, so other questions that I've got here from the other night. Can you successfully breastfeed with over-the-muscle implants? Okay, asking for a friend. So yes, you can breastfeed with over-the-muscle implants. The implant itself is still underneath the breast tissue. The nipple in itself is still attached to the breast parenchyma or tissue, and the ducts are in communication. So, and the breast tissue is still responsive to hormonal influence of the brain to increase in size when required. So yeah, you can still breastfeed with over-the-muscle implants so long as the nipple is still in connection with the breast tissue. One of the techniques of, say, a peri-areolar incision, it depends on the training of the individual involved, but if they make an incision underneath the nipple and then sort of head down just across the top of the breast tissue and then get underneath, then the nipple is in contact. But some people lift the entire nipple up or split underneath that, and that can divide some of the key ducts that actually allow the breast milk to get through to the nipple itself, and so you can have implications for breastfeeding with that. The other part of that question essentially is, the other opposite is can you breastfeed with implants that are under the muscle? And obviously the answer is yes. Can you breastfeed with a dual plane procedure? The answer is yes. It all comes down to the nipple being in contact with the breast parenchyma. Okay. Can you breastfeed after a breast lift or reduction? The answer is yes, and it's backed up with research. All of this sort of stuff. When it comes to breast reduction patients, that's a really common question or it's something that I'll bring up in the women that come through that haven't had kids yet, and that's a really common scenario. And so, the evidence shows that 70% of women who have a breast reduction before having children will go on to breastfeed successfully. And the remaining 30%, when you actually analyse it, a lot of the time it's because they have concerns about they just didn't want to breastfeed, or they were concerned about how their breast shape might be affected by breastfeeding. But as long as the nipple is kept in contact with some breast parenchyma, then usually you can breastfeed. There's a question here about revision breast surgery, and this is a big part of my practice. So previously I had an areolar lift. So a lift procedure can be done in multiple different ways, but an areolar lift essentially is usually for a small lift, and with implants 8 years ago. So that's a technique where obviously they've made that peri-areolar incision, they've used that as an access point to put implants underneath, and then they've completed the incision around to actually then cut out skin. So essentially they're cutting out a donut of skin, the nipple being in the middle, that being around there, and then they're closing the skin onto it. Okay, now areolas are now stretched to a much bigger size than prior. That is the commonest scenario after having an areolar lift. Okay, our skin in general over about the age of 35 just starts to lose its elasticity, and scar tissue is only ever 85% as strong as normal skin. So if you inherently have a scenario where you had all of this stretch, and then you've needed a lift, and then you've got to put an implant behind that, then you've got, number one, a construct of skin. That skin is made up of collagen and elastin. So collagen are like these really tight little structural beams, and then in between they're held by this elastic tissue that allows it to sort of move and stretch. So if you have a scenario where you put on lots of weight or just gravity does its thing, then essentially those elastic fibers can separate. They can weaken, they can be stretched, and so you've got this tissue that's mainly all collagen but not much recoil. You go and cut out that extra skin to try and make it all tighter, but the inherent skin with the lack of elasticity is still there. And then you add the concept of something behind it that's applying a force, and that's on a scar that's only as 85% as strong as normal skin. So you tend to see a situation where the areolas stretch up. So that's really common with the central, like round block type mastopexy type scenario with a lift. What do we do about it? There's a comment that says here, now stretch to a much bigger size than prior, plus everything's dropped a lot. Okay, is it possible to have a revision lift, decrease the areolas, and pop in slightly larger implants without impacting the areola and potentially losing them? Okay, so yeah, you can have a revision lift. Can you decrease the areola size? Yes, that can be incorporated into that revision lift. Can you pop in slightly larger implants without impacting the areola? So if you think about what I was just describing in terms of all the forces, all the issues there, the scar tissue, all of that, you can, but you risk doing the same thing again. In terms of a widened or stretched scar, or an areola that again is stretched again. Can you potentially lose your areola? Yes. It comes down to how much pressure you're putting on the construct. We think as plastic surgeons about blood supply. And so you're thinking about keeping something alive, it has to be nourished by blood in and it has to get out. So if you have something that's putting a lot of pressure on something, then it's like anything. If you've got a hose in the backyard that's just spraying water everywhere and you can't actually get to it and the washing's getting wet, you run over it to it and you'll try and stand on it and then reach down and grab it and kink it. Okay, so if you go and make something too tight or you put something that's big, like a big implant behind it, then those blood vessels, which are like the hose, okay, if you have something that pushes against it, then it's no different to standing on the hose. And so you can affect the blood supply to something. So if you make the nipple smaller and too tight and put something behind it, then you can affect the blood supply to the areola and it can die. So that's a potential consequence, and that's something that we're aware of. Like, you have to factor that sort of stuff into your surgical planning to say, hey, this is a potential risk, and so considering that, what's safe, what's wise? Should we be going with something that's a smaller implant? Should we be going with something that it's a bit different in approach? You don't have to go through the same incision and do all that sort of stuff. Maybe we go through a different area and do something different with the nipple, or do that as a second stage. So there's things like that where you've got to see someone who can give you some pretty good advice on what would be the safest way forward. That's a big discussion to have. Okay. Now, other questions that are coming through. Bits and pieces here and there. One of the things that I get asked about a lot is the scarring in an arm reduction. Okay, and that's something that I think if managed properly, scars in general, and most people should be thin. When I am looking at scars and scars in my life, I am thinking about the physiology behind how you heal, and I'm thinking about sorry, there was another question that just popped up. So I'm thinking about how it heals in terms of what our normal processes are as a human being. And I'm thinking about not just the short term, but also down the track. So it takes 3 months for your scar to reach the maximum strength. So you've got to think about how we close a wound and doing it gently, not sort of, as I was talking about. Like, you can traumatize the edge of the skin, you can affect the blood supply of the edge of the wound. It can really run into a lot of trouble just at the wound edge, just from rough technique. So you've got to factor that in with good tissue handling. You need to think about how you stitch wounds, and you've probably seen, like, there's sutures that are on the outside, and then there's a potential to put sutures on the inside. Now, plastic surgeons, we don't tend to use a lot of external sutures on things, okay? And unless it's facelifts or on the face, where we sort of want to line up the very top layer of the skin to get the best scar. For the rest of the body, we tend to use a lot of internal stitches. External stitches, if they're left in from 7 days on, they start to leave those little dots either side of the wound, so you get that little caterpillar track type look, which just looks terrible. So at 7 days, if you look at how a wound is healing, it's really weak. You know, if I have someone that at 7 days, all they've had are external stitches, you can push on the wound and the whole thing will fall apart. So plastic surgeons, we put stitches internally to hold things together, and obviously an internal stitch doesn't have the dots either side. So you have a stitch which hangs around for longer, and it gets you through that period of time so that your wound edges are kept together for longer and you don't get the widening. When you get a reduction in wound strength, you get widening, and the body gets this stimulus to say, hey, I'm falling apart, and the body upregulates the blood supply, and then it starts to upregulate how much collagen it dumps into that area. So you get these big, thick, pink, purpley scars. So that can happen sometimes in areas, but you can try and avoid it with internal suturing. Now, in the arms, for example, that's somewhere where internal sutures are really key. I see lots of cases, as I pointed out at the start, I am the Director of Plastic Surgery at the Royal Brisbane, and I see lots of cases come through that are from overseas with cosmetic tourism. And for whatever reason, lots of external sutures are used. People are told, you know, yep, you've got stitches in, leave them in for 3 weeks, and then see someone and take them out. There'll be problems that come up, they come through our emergency department, and then you're in a situation where all we've got is external support, terrible tram track sort of lines, and they just heal badly. So you see the consequences of not having that internal support. I see it in the arms commonly because the skin is thin and it's an area where the bicep muscle wants to sort of try and pull that scar apart. So we see thickened scars in that zone. In conjunction with internal sutures, we do a lot of external taping. So most plastic surgeons will tape the scar for 6 to 12 weeks to get you through the point where you get to the maximal strength of the scar. So all of my patients, they're used to me sort of saying, hey, you're going to be getting taped for 12 weeks. And it's something they get used to. They change the tapes weekly and they shower with them on, all of that. If they get any tape reactions, we can change to different tapes. It's a really important part of your wound management. Okay, and I apply that to every wound. We've got a few more questions coming through. So Irene has sent one through. After having a breast augment and losing any sensation in your nipples, do you ever get that back? I'm 17 weeks post-op. Okay, so the nerve supply to the nipple comes off from around the 4th rib from the side, and there's also supply from the front. So there's 2 sort of areas that come towards that zone. Keep in mind, a nerve, if you fall asleep on your hand in a funny position, you sort of wake up and suddenly it feels really numb and horrible. We've all been through that. And it takes a bit of time for that to recover. So nerves can be injured from being stretched or positioned in a funny way, so they can undergo sort of that temporary paralysis, and that affects sensation, or they can be cut. Now, the nerve in that little lateral part through there, in an augment, because that's an area where I go through all the time, it's a pretty sneaky one that comes around the wall, okay, around through the side there with the skin. And it's something that you can suddenly come across when you're trying to release things there. It can be super thin, it can be a little bit thicker. It's reliably sort of in the zone that's on the lateral aspect of the muscle in that cortical pec minor. So it's something that I look for as a routine and I try to preserve. Even when you preserve it, think about the implant and the fact that it might be putting pressure on, which again comes back to my analogy of, you sort of wake up and you've been lying your arm in a funny way, you've been sitting on, on a chair in a funny spot for too long, and you've woken up with a numb leg. So if an implant is pressing against that nerve for too long, then it can affect sensation. It might be that the nerve's not necessarily damaged or cut, but there's a pressure there. How will that improve? Will it improve? Potentially. It's something that I just counsel people and say, hey, the mechanism behind this is either that it was cut, there was bleeding there, it's a diathermy, and the heat from the machine we used to stop bleeding has traumatized the nerve, or there's a pressure effect. Is there extra swelling in the zone which is putting pressure against that? So the answer is time, and just letting things evolve and seeing, is this something that's improving, and having potentially an expectation that it may not improve. So give it some time, see what happens, okay? It can be swelling that is contributing to, or extra fluid around the implant that's contributing to a pressure effect. Wearing a garment that sort of pushes the implant away from that area sometimes can help. Time will tell, okay? I hope, Irene, that's given you an answer to your question. Now, I've got a question here from Tracy. Hi, with the arm surgery, for someone that is pear-shaped and has lost 55 kilos but still just over 200 kilos, will the surgeon do the operation without being at goal weight, even though due to body shape, most of the weight loss has been upper body? This is a really good question, because essentially a lot of the decisions that we make as surgeons are based on research that is looking at rudimentary measures of someone's overall health. So one of the things that you commonly hear about is something called body mass index, or BMI. The research looking at that is looking at wound healing and wound breakdown, and there's all these curves that show that BMI that's sort of less than 25, you're looking at wound healing and breakdown concerns that are less than 1%. And then you get up around 30% and you're just getting a bit higher. BMI 35, you're getting up to 13% to 22%, depending on what you read. Getting up to BMI 40s, where you're looking at complications with wound healing and breakdown approaching 100%. But that's very different to a localized area. So certainly if it was an abdominoplasty and you weighed 200 kilos and you have all this fat and tissue, then that research is relevant to that particular scenario, and I would counsel you, or counsel a patient in a similar situation, to say, you're not at your ideal weight for this procedure. For the full tummy tuck, for example, sometimes we do apronectomies and things just to amputate that extra skin so that we don't undermine things. We try and minimize your wound healing concerns, and that can be safe if it's done properly. So coming back to your question about arms, the relevance of the BMI and the goal weight can be fudged a little bit, but that's just based on the wound healing and that research, and how does it apply to your arms as an example, as an area. The other thing you must keep in mind, though, is your potential anesthetic risk. And for the arms, to do that properly, you require a general anesthetic, and that's where you need someone who needs to weigh up your anesthetic risk profile. And being a weight of 200 kilos and having all that weight on your chest, and then thinking about ventilation, and thinking about blood clots, and thinking about exposure and temperature and all sorts of things, there's lots of science and research to support you being a higher anesthetic risk profile than not. So the goal weight and getting it down can improve your overall anesthetic risk, which for elective surgery is something that does need to be considered in the whole picture. So again, it's a case-by-case basis, analysing the area, analysing the patient, and thinking overall risk-benefit profile, and then working out what's safe. All right. Tracy, I hope that's answered your question. Shay Kempster, believe it or not, I've had compliments on my scars, especially my arms. Thanks, Matt. Good. And Irene's happy with things. Okay. An operation that I get asked about pretty routinely is one that you don't see on lots of forums, but it's two areas we should talk about. One is a back bra lift. So that's dealing with all that tissue that's sort of on the side there, and then on the upper back. And a belt lipectomy doesn't address it, because it's all the tissue that is attached to the shoulder blade and the ribs in that zone. So it's all sort of draped up, and then it sort of hangs down to the sides. It's a sort of area that a lot of women find really frustrating once they've lost lots of weight. Okay, so Tracy, thank you for typo. I meant just over 100 kilos, not 200. Anesthetic risk, as I said. So if you're just over 100 kilos, then that's a totally different scenario to over 200. Okay, that's case by case, analysing the situation, looking at the arms, and then considering the whole sort of weight distribution thing there. And if the arms are not under too much tension and aesthetically you're safe, then target BMIs are a guide. Okay. That becomes a little bit unfair as a measure. So some people on here may be aware of the criteria that I have to work within the public hospital sector. And we get referred lots and lots of cases, and we have to make decisions on taxpayer dollar operation and who should get what. And we have to have certain cut-offs. I'd love to see every single patient referred for arms, tummies, everything to the public sector, but it's one of those things where I've got to think, okay, I've got 18 UK slots on a Thursday morning, and if I spend 18 cases saying you can't have this, you can't have this, you can't have this because your BMI is too high, or there's some other complicating factor like smoking, then obviously that's a waste of an opportunity for someone who's more appropriate. And so that's one of those scenarios where we have had to bring in BMI criteria within the public sector based on the research to try and triage things a bit better and to direct advice back to general practitioners on who's appropriate and what sort of things can be done and what sort of targets to help work towards to make things safer. So yeah, BMI, although it has to be considered in some scenarios, it is a guide to actually direct healthcare and the expenditure of the public purse, unfortunately, but that's just how it is. So yeah, one of the things that I was just bringing up before was the back bra lift. Okay, so patients that I've done that to have found that really useful in terms of just addressing all that excess skin that sits on top of the bra strap, whether it be under the armpit or in the back area there. It improves the waistline by pulling it up, and it gets rid of that loose skin across the back. So that's a procedure that you do see discussed on forums, but it's surprising the number of patients that will say, oh, is there anything that can be done about this? And yes, there is a technique to improve that, okay? The other area that's just never discussed, but as soon as I bring it up, everyone goes, oh, yes, please, is the mons and all that loose tissue when you put on so much weight and then you lose it, or you have a cesarean. So when you have a cesarean, the number of times that I see that scar sort of pull right in and then you get this bulge down your pubic hair area, that's an area where when you actually bring it up and say, look, I've got to make this cut down here, and it's not something that I say, hey, come up, look at this. It's something that I say, and if you've got concerns in this area with a bit of a bulge, I can go and lift things up and resuspend and cut out extra skin. It's surprising how many women actually say, hey, that's a big problem for me. And so when considering a tummy tuck, belt lipectomy, any of those things, it's something to bring up with your plastic surgeon if it is a concern to you, because it's something that a lot of us just don't really volunteer because it is a sensitive discussion point. So don't be afraid to bring it up is what I'm trying to say if it's a concern to you, because it is something that can be addressed during a tummy tuck, resuspending all that stuff, and making a really personal concern less of an issue in terms of being a sensitive issue to you moving forward. One of the other things that I've got listed here that I did want to talk about is there's a lot of chatter about fat injections into the breast and fat injections into the buttocks. So this is something that the Americans have been pioneering, as a lot of you would know, and fat injections into the buttocks, if we go to that first, there's a paper and a position statement released by the American Society of Plastic Surgeons, published in the journal that we all sort of go to, which is Plastic and Reconstructive Surgery, or PRS. And it was talking about the safety profile of buttock fat injections. It sounds like the ideal scenario. You don't like fat here, so we're going to suck it out and we'll inject it into somewhere where you'd rather have it. I do lots of buttock surgery for cancer reconstruction. And the blood vessels that I encounter in that area specifically can be bigger than my finger. And this is something that they've shown there's so much vascular anatomy in that zone. And as bizarre as it may sound, if you're injecting fat into the buttocks and you happen to hit one of those blood vessels and inject fat into that, that fat can break off and go to your lungs, and that can stimulate a really inflammatory state in the lungs, It's called a fat embolus, which is a break off of fat heading up and gets trapped in the lungs. The lungs are essentially like a sponge. And the fat gets trapped there, it sets up a big inflammatory state and affects your breathing, and you can enter into a state where essentially the end result can be death. So we had a big discussion about this at the annual Australian Society of Aesthetic Plastic Surgery group in Melbourne last October. The risk profile that was being discussed is getting into the territory of open heart surgery. So for something that's aesthetic and trying to give you a better look, it's carrying a death rate that's similar to modern day cardiothoracic surgery. And that, to me as a surgeon, is too high risk. And the American Society have essentially published similar sort of data that a lot of people aren't aware of and you need to be aware of. So if you are considering liposculpture and sort of having fat removed but then injected back into the buttocks, it is a high risk zone and you need to be aware of that risk. Now, getting back to the breast side of it, the Americans have been pioneering fat transfer into the breast instead of using implants. And that's been going on for a while. Roger Curry is based in Florida, and he's the guy that's on the conference circuit talking about his experience. And he is transferring fat and he's seeing results that he publishes and says are okay. There's lots of debate about that. If you inject fat into a breast, what does it look like under ultrasound or imaging if you're looking for breast cancer? Lots of research showing techniques and ways to work that out and differentiate so that it's safe. What happens when you take fat and inject it up into a breast, which is a hormonally sensitive area? 1 in 8 women get breast cancer. Are you transferring stimulus cells from one area into another? Are you stimulating an area of inflammation to cause a cancer? And that hasn't been, there's no increased risk really shown with that, but it's one of those theoreticals or hypotheticals about is it possible? And I don't think it's been going on long enough to actually say yes or no. But it is happening, and there's been a slow pickup of that in Australia because our medical indemnity providers have all sort of basically said, hey, we're watching this space. And some of them are starting to change their position on that. So you might find surgeons around that are starting to do that. But consider the training and just investigate it a bit further before you jump in. It sounds ideal, but you have to weigh it up in your scenario and really read the research around it. Now, there's a question here from Tracy. I've seen recently thigh lifts with scars on the outside of the leg, not the inside. What is this op called? Again, for a pear shape with saddlebags. Would this be better, than the inner thigh lift? Okay, so you've got to think of the body in terms of, go to the pub and look at some fella standing there at the counter and massive beer gut, and then he's wearing this tiny pair of shorts. And that's because the way that our body is set up, we have these things called zones of adherence. So essentially, your skin is connected to the underlying structures by ligamentous or sort of fibrous attachments. And that's what keeps things where they are. If we didn't have those, then everything would just fall off. So big gut, but there's a zone of adherence underneath it, which explains why all that fat just doesn't continue to fall down. If you have a look at your own lateral thigh, you'll notice that there's quite a zone of adherence on the lateral part there, okay? So there is an area where no matter how large you are, it sort of comes in and then out. So there's a zone of adherence along what's called the iliotibial band. Now, that is an area where if you were to have lots of loose skin in that zone, your surgeon would have to be thinking about the position of that of that iliotibial band, that zone of adherence. Are they using it as a fixation point to try and sort of pull things to, or something else? This is not an operation that I've ever personally done. It is an area that I'll place a scar when I'm trying to harvest other tissue for use in lower leg reconstruction, head and neck reconstruction. There's a flap that we use on the lateral part of the thigh called the anterolateral thigh flap. When we close that down, do we see a significant change in the profile of the thigh? Not routinely. It might be that we reduce the overall caliber, but when I see patients that have lost lots of weight, it's that medial fat pad right at the top there that's been stretched out, and then you've got this loose skin that's all sitting in there. And by taking away from that zone and trying to get that to pull around, keep in mind the further away I'm cutting away something, the less effect I have at the distant side. So it's better to localize your cuts over an area where the problem is than to sort of try and put it somewhere else. And especially on the lateral part of the thigh, that scar, I think it's more obvious than a medial thigh scar, in all honesty. So I need to do more reading around to see what it is they're trying to achieve. Could it be that we've got loose skin after liposuction in an area in that lateral trochanteric zone, and they're just trying to tidy up that loose skin in the upper part of the thigh? Because certainly once you get beyond that fat deposit, most people's lateral thighs have got that iliotibial band that keeps the skin pretty tight, but their bigger issue is on the medial part. So that's why our procedures are focused on that medial part, to cut out that extra skin and then tighten it this way. Okay, but yeah, let me look around. I haven't seen that, and it might be something that's published in the journal. Okay, other questions that I get in relation to body contouring is in terms of facelifts, and this is something that the neck is something that's really common for people, and so okay, getting the wind up because we've been talking. I'm starting to get husky, I think. But yeah, don't forget about the neck. Okay, so I'll finish on this as a topic. The neck is something that you can get that sort of gobbly type thing through there, and then when you get muscle separation as we get older, that can be something that can be addressed. So doing an isolated neck lift is something which is really useful for lots of people in body contouring, so it's something to keep in mind, in addition to just repositioning fat pads on the face. So a facelift is another thing that we see in body contouring. Anyway, I'm going to leave things there unless anyone has any other questions. I'd like to thank you all for your attendance tonight. I'd like to thank Trish for facilitating this. I find things like this very useful, just to sort of hash through some pretty big topics that just give you some general advice and guidance that you just otherwise have to see and pay to see a plastic surgeon to discuss. So I hope it's been of use to you. If I can help you as a surgeon, I am based in Brisbane. I'm at Valley Plastic Surgery in Fortitude Valley. I do lots of breast and body contouring. I do lots of skin cancer work, lots of augments and reductions and lifts and breast reconstruction, post-cancer, facelifts. When it comes to noses, I send them all across to Ray, my partner in crime, because I do feel that he's very competent at that procedure. But anything else that I can possibly help with, don't hesitate to reach out. Anyway, thanks again for your time, and thanks Trish for facilitating that.